Good morning, everybody, and welcome to the 21st edition of the Academic Cover brought to you by the GMOA Academic Subcommittee, coming to you live from GMOA office. So today we will discuss about varicose veins and its management in the primary healthcare setting. So before we start, I would like to remind all of you that you can post your questions in the chat box, and we will be going through the questions, and at the end of the lecturer will be able to answer these questions. So don't forget, if you have any queries, any questions, please be kind to forward them through the chat box. So today, to discuss about varicose veins and its management in the primary healthcare setting, we have Dr. Sachith Abeywickrama, consultant vascular and transplant surgeon from the National Institute for Nephrology, Dialysis and Transplantation of Colombo. So I would like to invite Dr. Sachith to take over and explain and share his knowledge with our learned audience. Over to you, Dr. Sachith.
Good morning, everyone, and thank you very much for joining us today at this hour for this presentation. I warmly welcome you all, and I would like to thank all the office bearers of GMOA and especially the academic subcommittee for giving me the opportunity to educate you on the management of varicose veins. So I'm going to keep this as simple as possible, and I'm going to highlight the main points which will be important for you all in the management of patients with varicose veins at the primary healthcare system. So first of all, I would like to introduce what varicose veins are by defining what are varicose veins. Why I'm going to do that is, sometimes you might come across patients like this. So are these varicose veins? What do you think? No. The picture in your left side of the screen, there's a patient who is a muscular man who is probably working out frequently, having very prominent veins, isn't it? So these are not varicose veins. So these are prominent veins which are a result of muscular exercises. So those are not abnormal. Those are normal veins which have become prominent. So they don't need any treatment. And picture on your right. So there's a young lady with visible veins. So those are necessarily normal veins, normal caliber, but they are visible because of her skin color and the texture. So if you come across these kind of patients coming to you asking for any treatments for varicose veins, you should reassure them saying that these are not varicose veins. So if that's the case, what are varicose veins? So varicose veins are dilated and tortuous superficial veins. So when I say superficial veins, I would like to just remind you a little bit of anatomy, not very much. So our venous system has three components: superficial veins, deep veins, and the perforators connecting them. So due to a problem either in the superficial veins or else in the deep veins, sometimes these superficial veins can dilate and become malfunctional. So those are called varicose veins. Okay. So varicose veins are very common in the lower limbs. You know why? Because of our upright posture as humans. Gravity puts pressure on the venous circulation of the lower limbs. So therefore varicose veins are common in the lower limbs. And also it's very common everywhere in the world. So statistics say 1 in every 3 to 4 adults will have varicose veins. So that is because we have obtained an upright posture in our development, and that's why you don't see varicose veins among animals. It causes significant morbidity, and very rarely it causes mortality. So varicose veins rarely kill patients, but it causes significant morbidity and put a huge burden to the health system. But fortunately, we have good treatment options. Most of them are minimally invasive with good results. Okay, so what happens in varicose veins? Just in 30 seconds, I'll explain. So there is malfunction of the superficial veins. So there should be valves in the veins in order to stop blood from coming back when we are in the upright positions. So the muscle pump will pump and compress the veins and push the blood towards the heart, and there should be a valve system to prevent it from coming down. So when there's malfunction of these valves, there's blood pooling in these blood vessels causing high venous pressure, and that venous pressure start causing problems, isn't it? And when there's blood pooling, when there's blood stasis, so the chemical components and the cells which are there in the blood try to migrate through the vascular wall, which is not a rigid wall as such. They can migrate, and it can cause symptoms and complications of the varicose disease, and which is the reason for patients to have this morbidity. Okay, if you have any questions about this, please ask me. At the end of this, I'll explain more. Okay, right. So now come to the important part. A patient comes to you with suspected varicose vein. First of all, you should be able to diagnose, okay, this patient has varicose veins by looking at him. Okay, so towards the left of your screen, there's a patient with varicose veins. So there are dilated and tortuous veins in the leg, which are definitely abnormal. And what are the clinical features a patient would come to you with? So most of the patients will tell you they have pain, but as clinicians, you should interpret this pain very carefully, because most of the time this pain, not most of the time, sometimes this pain may not be related to varicose veins. Patient come and explain you they have leg pain, and obviously they have varicose veins which are visible. So before attributing the pain to the varicose veins, you should get a good description about the pain, because sometimes it may be arising from joints, sometimes it may be a result of radiculopathy due to nerve compression at the vertebral column level. So therefore you should know what is the typical pain of varicose veins. So typically it is a heaviness or a discomfort felt mainly at the calf, not on the joints, at the calf on prolonged standing, and patient get a relief of the pain by keeping the legs up on a bed or else putting some pressure onto the leg. Okay, and it should not be a sharp pain or a burning type pain coming from the lower back radiating through the leg towards the foot, and it should not be a joint pain which stop the patient from mobilizing or walking. So therefore, before you attributing the pain to the varicose vein, you have to make sure that this pain is coming from varicose veins. Why? Because otherwise, once you treat the patient will come back and say, my pain is still there. You have treated my varicose veins but my pain is still there. So therefore, you have to identify what the patient's pain is. If you are in doubt, sometimes some patients complain of pain, not the typical pain, but you cannot attribute it to anything else also. Then what you can do is you can ask them to put class 2 compression stockings for about 2 weeks and come back and say whether there is a response. If there is a good response for stockings, the pain is likely coming from varicose veins. So other than pain, what else? Patient can present you with swelling or muscular cramps, eczema, just like in this picture, which is itching, causing changes in the skin, ulcers, and sometimes history of bleeding. Okay. So once you diagnose clinically, we do simple venous duplex. One thing is to confirm the diagnosis. Other thing is to plan our interventions. Okay. Why? Because the varicose veins happens maybe due to a problem in the superficial vein junctions joining the deep veins, namely saphenofemoral junction or saphenopopliteal junction. Or else sometimes it may be secondary to a perforator incompetence. You know, perforators are the veins which connect superficial veins to deep veins through the fascia. Okay, so by doing a radiological study, a venous duplex, and you can identify where the problem is. Okay, that is important in planning the further management. Okay, then the etiology, as I said earlier, sometimes varicose veins may be a problem in the superficial vein itself, or else it could be secondary to a problem in the deep veins. If you get deep veins, let's say in the femoral vein or external iliac vein, there is pressure to saphenous vein draining blood to the deep vein, because the deep vein is obstructed. So therefore you can have secondary varicose veins after the DVT. So that demarcation or that categorization is important in the management. Okay. Then the most important question, or the most frequent question the patient would ask you is, why have I got this? So sometimes you can say, there are risk factors for varicose veins, such as high BMI and history of abdominal surgeries, okay, history of DVT, family history, age, and the female gender because of the multiple pregnancies. You can say now there are risk factors which can cause varicose veins, but most of the time you cannot pinpoint and say this is the reason. Since it's a very common condition, in most of the time we may not be able to exactly say the etiology of this problem to the patient, but you can say it's a common condition and you don't have to worry about it. It's not a very dangerous condition and we can always treat. Okay, then you have to assess the severity of varicose veins. What is the effect of these varicose veins on patients? Okay, and then the presence of complications as ulcers, bleeding, things like that. Okay, and don't forget to check the pulses of the foot, because if you are trying to put compression, it's important to know the arterial perfusion of the foot. Otherwise, you might make the condition worse. Okay, right. So this is a duplex finding of a varicose veins causing reflux. So you can see in this, once you make a compression to the vein, okay, so this one, there is a reverse flow in the vein, which ideally should not be there. Okay, in a normal vein, if you put a calf compression, the backward flow should stop like this because of the valves. Since the valves are not working, the backward flow continues. This is we call reflux. Okay, right. This one, of course, you don't have to concentrate much. SEEP classification is a classification system we use to classify varicose veins patients. Right. Next question: should we treat all the patients with varicose veins or not? Right. Patient would come to you with varicose veins, and you are the clinician. You should decide whether to treat or not. So what do you think? Should we treat all the patients with varicose veins or not? Otherwise, who are the patients who needs treatment? Okay, but all the patients need this magic medicine, which is the reassurance, because that is the most important medicine in the treatment of varicose veins and also the treatment in most of the other conditions. You have to reassure this varicose veins is not a lethal condition. You are unlikely to die of varicose veins, and we have a lot of management options available at the moment. Most of them are minimally invasive, okay, not very complicated interventions. So therefore you have to reassure the patient. Okay, so then you have to decide which patients need treatment, or else when to treat, right? So simply I categorize them into two categories. So one thing is, if the varicose veins start causing problems to the patient, how? Pain, swelling, eczema, skin changes, ulcers, or spontaneous bleeding. That means varicose veins troubling the patient. So you have to treat them. Okay. Sometimes some category of patients might come and say they don't have any of the symptoms, no complications, so varicose veins are just there. So then what do you think? What do you do? No pain, no swelling, nothing. Varicose veins are there. Asymptomatic patients. So out of the asymptomatic patients, some would say they have a cosmetic disfigurement. So that sounds a bit of a complicated word, but what that means is, especially the young females, so when they wear a short skirt, these varicose veins are visible, so which causes a cosmetic disfigurement to them, and which is a problem actually. Then of course we can treat it. That is an indication. Okay. Sometimes we meet middle-aged women coming with varicose veins, asymptomatic. They don't have a cosmetic disfigurement as such, but they have a psychological worry. So they are thinking about it all the time. Will I die with varicose veins? So will I lose my leg with varicose veins? However much you try to reassure. So it's a psychological problem to them. So in that case also you can consider intervening. Okay, so those are the indications. If the patient doesn't have any symptoms, any complications, any cosmetic disfigurement or psychological worry, if they are totally asymptomatic, you can observe them. Okay, so then you have to reassure and observe them, and you should tell them if this get worse or if you start getting any problem, then come back, we'll treat. Okay, then the patient might ask you, what will happen to this? Will it get worse? Or what will be the cause of this problem? So it's very difficult to predict the natural cause of varicose veins. But what you can say is, if the patient is obese, so you can advise them to lose some weight so that this will get better. Otherwise it will get worse. So otherwise in normal patients, very difficult to predict which patients will go into the complicated stage, and sometimes it can remain like that. Okay, so therefore the best thing to say is, at the moment there is no indication for us to treat this. You keep an eye on this. If this condition gets worse, come back and we'll treat. Okay, right. Before going into the management options of varicose veins, I would like to highlight two common scenarios you might come across in the primary health care. So how do you manage a patient presenting with bleeding varicose veins in the primary setting? Let's say a patient with varicose veins come to you with history of bleeding. It may be a minor bleed, sometimes it could be a major bleed. So what you should do is, first of all, you will have to control bleeding. So this is bleeding from the venous circulation, not from arterial circulation or not from a AVF. So it's a low pressure system. So therefore, simple pressure applied by pack of gauze and putting a bandage, crepe bandage around it should settle this bleeding. Okay, so once you control the bleeding, then you must advise the patient to get varicose veins treated as soon as they can, which is not an emergency. You don't have to transfer the patient overnight in an ambulance to get the treatment, but you have to treat it as soon as possible, because once it bleeds means it can bleed again. Okay, right. The pictures which are there in this slide from a 79-year-old lady who has been found dead in an apartment, not in Sri Lanka, in Italy. I think 79-year-old female, this is from a case report, found dead in an apartment after bleeding from varicose veins, which is not a very common condition, very, very rare. So, but if the patient is dementic, or if the patient is a heavy alcoholic for that matter, then this can happen. But otherwise, if the patient is conscious, rational and otherwise fit and healthy, this is unlikely to happen, because they can always control the bleeding. Okay, so key points to keep your mind is, control the bleeding by applying pressure and advise the patient to get it treated as soon as they can. Okay, right. Then few words about venous ulcers, because I know these venous ulcers are very common. Most of you in the primary healthcare system and in your practices, you must encounter these kind of patients, and a lot of these venous ulcers unfortunately are mismanaged. So therefore the patients get it worse and sometimes come to the tertiary care when they are having very complicated ulcers. Okay, so management tips. First of all, you have to identify the venous ulcer. So from medical school days, we know venous ulcers occur mainly in the gait area of the leg. Gaiter means the area of the leg which is just above the ankle. Okay, and those are very superficial ulcers, not very cavitated ulcers, and they produce a lot of oozing or exudate. Okay, and the surrounding area is erythematous, and the leg will have features of venous insufficiency like varicose veins, eczema, the blackish discoloration, likewise. Okay, so once you identify the venous ulcer, two things you should do. One thing is, you should scan the patient and identify underlying varicose veins and treat them. Treating varicose veins will enhance or expedite the healing of venous ulcers, which is statistically proven. and after intervening, you will have to continue compression. So you must have heard this word, compression therapy or strapping, right? So the treating varicose veins is also important, but that itself is not going to heal the ulcer. After that, you have to continue 4-layer strapping or compression. I'll tell you how to do it until the wound heals. Okay? So things which are done to harm the wound by the clinicians are, one thing is putting gel into these wounds. These wounds are already produces a lot of exudate, so they are already wet. So putting gel onto that is not going to help. Okay, so you should put absorbent dressings like hydrogel or else the silver absorbent dressings, okay, to absorb the exudate so that it will keep the wound dry and it will enhance healing. Okay, so don't put gel onto the varicose veins, venous ulcers. You can put gel to the arterial ulcers and diabetic foot ulcers. That is different. Etiology is different. But here you should put absorbent dressings on the ulcer, and then you should do the 4-layer strapping starting from the toes up to the knee. Okay, at least every weekly. But if the wound is very exudative, sometimes you might have to do it twice a week as well. Okay, so that's the management. Treat the varicose veins, compression. Before putting compression, make sure you check the pulses all the time, because sometimes these ulcers may be mixed. Patient has venous disease as well as arterial disease, and if you try to compression, the arterial perfusion may further reduce and patient will have limb ischemia. So check pulses. If the leg is swollen and you can't feel the pulse, get a duplex done, assess the flow. Okay, right. So when you should worry, now you keep on strapping, you treat the varicose veins, but it doesn't heal. Okay, so then sometimes these long-standing venous ulcers can convert themselves into this. What is this? This is a Marjolin's ulcer, which is a squamous cell cancer of the skin, happens on a long-standing ulcer. If you see something is not right in the venous ulcer and you are treating it for so long but no response, having said that, venous ulcers will take time to heal. I mean, you can't heal it overnight, but at least it should show it should show the signs of going in the correct pathway. The wound size should start reducing with time. But if you come across with a wound which is not looks good, smelly, and there are sort of features suggestive of a squamous cell cancer like this, then always refer the patient to a tertiary care center. Okay, right. So keep in your mind how to tackle with the patient with bleeding varicose veins and how to manage a venous ulcer. Right. Let's get into the treatment options now. Okay, so now we discuss what are varicose veins, how to clinically diagnose them, how to do the duplex, and how to decide whether to treat or not. Okay, I hope it's clear up to now. All right. Okay, then what are the treatment options? There are so many treatment options available all over the world, but I'm not going to discuss each and every treatment option at this talk. So I would like to highlight things which are commonly used, especially in our setup. Okay, right. So there are non-invasive treatment options like compression therapy using stockings, and there are certain drugs which are used for treatments of varicose veins. The most commonly used one is Daflon, which is actually a drug which was used for hemorrhoids, but now it has come to the market for the treatment of varicose veins. When you are prescribing this Daflon to patients with varicose veins, you should be very careful, because it's not a magic bullet which is going to cure varicose veins. Okay, what it has proven is it can reduce the venous tone of the patients. That's what it does in the hemorrhoids as well. So when you reduce the venous tone, sometimes it can reduce the pain patients are experiencing from the varicose veins, the heaviness I talked about. Okay, but when the patient comes with complicated varicose veins, ulcers, bleeding, don't give Daflon and send the patient home. It's not going to do any good. All right. So Daflon should be used for patients with varicose veins at early stage, patients has pain, okay. So, but it's not going to sort of cure varicose veins. It will reduce the tone and give you a symptomatic relief, okay. So, daflon should be prescribed, I think 500 milligram BD to be taken with meals, okay. So, there are so many other drugs which has been tested but not proven, not given us good results. So, I am not going to tell about those drugs. This is the drugs we also sometimes use, but use it carefully, okay. Then we have minimally invasive options. Sclerotherapy, I am sure you all know, right? Then thermal ablations like radio frequency, laser, and mechanochemical ablation like putting glue, and also the invasive treatment options. Open surgery, which was the treatment option for varicose veins in the past, but nowadays it's sort of losing its popularity. Right, then you have to make a decision, right? This patient needs treatment. So what is the treatment option I'm going to offer? Whether it is non-invasive, whether it is invasive, or whether it is open surgery. So how are you going to do that? First, you should know the stage of the disease. So what I mean by the word stage of the disease is where the problem is, whether it is an isolated varicose veins, or whether it has a perforator incompetence associated, or whether it has a truncal reflux at the SF junction or sapinopopliteal junction, okay. Or else, whether it is a primary problem has happened in the superficial venous disease, in which case the deep vein should be normal, or else there is a problem with the deep veins. If there is a problem with the deep veins, whether it's a reflux in the deep veins, which can happen after DVT, or else whether it's an obstruction of the deep venous system. So you should know all this before starting the treatment, but simple duplex study will answer all the questions. But if there's a problem in the deep veins above the inguinal ligament in the external iliacs or the IVC, then you can do invasive imaging techniques like CT venogram like that, but rarely we use it because most of the time it's a superficial venous problem, okay. Then you should know the general medical condition of the patient, whether the patient is a moribund patient, not expect to live for more than few months, or whether the patient has his general medical condition is poor with heart failure or renal failure like that, and the body habitus, whether it's a thin built patient or obese patient, okay. Then you have to always ask what are the patient preferences. Some people will say, I don't want to undergo any surgery, any intervention, no injections please. So in that case, you are left only with non-invasive conservative management measures, okay. Then expertise and availability of treatment options in the hospitals of the Sri Lanka. So if the patient has varicose veins in the very initial stages, only has a pain which is not disturbing the patient too much, then you can say now there is no real indication to go for invasive treatment options. If the patient prefers, you can try compression stockings, but you have to tell them these compression stockings are not going to cure the varicose veins, but it can give you a symptomatic relief, okay. And if the general medical condition is poor, again patient may not be suitable for us to do any interventions, okay. So in that case also you have to go for non-invasive treatment options, okay. Compression therapy, which has been used for years and years, which is a graded external pressure. That means the highest pressure is being applied at the level of ankle, okay, and the pressure gradually reduces when it comes to towards the knee joint. So by that way it pushes the leg, presses the leg and push the blood away from the leg, okay. It will give you a symptomatic relief, okay. That is the same principle why we use it for venous ulcers, to reduce venous pooling, okay. So this external pressure reduces venous stasis and increase the flow, okay, which is a non-invasive technique. That's why I told you, if the patient doesn't want to get an invasive treatments, you can go for this, which is a cost-effective one, cheap, low adverse effect profile, hardly gives rise to any side effects or the complications, with good alleviation of symptoms. And sometimes it can reverse the complication also, but for that you have to use it in long term. Okay, what are the problems or the barriers to use compression therapy? One thing is non-adherence. Nobody likes to wear stockings forever, isn't it? Especially in a country like ours, where the temperatures are high. We can adhere to that had we lived in a European country. Okay, and cosmetically sometimes it's unsightly when you use stockings. Okay, and as I told you, you have to use it or wear it for longer durations. You can't wear it for a day or two and expect it to help you. Okay, so therefore the long-term cost could be high. So sometimes when you prescribe too tight compression garments, it can sometimes cause skin necrosis, but very rare, and obviously it will not cure the varicose veins. Okay, right. So these are the classes of compression stockings. For varicose veins, we usually use class 2. Okay, so you just have to prescribe class 2. So there are class 2, 3, 4 stockings in the market. Okay, so class 3 and 4 are for lymphedema. Okay, right. Then comes to sclerotherapy, which is a minimally invasive technique. I'm sure most of you must have given sclerotherapy for patients, right? So what we do is we inject a small volume of a sclerosant, which is a chemical. We mixed it with air to, why do we mix it with air? To increase the effect. When you mix it with air, so it forms bubbles, so that the drug or the sclerosant will be there in the bubble. So therefore it will sort of adhere to the more surface area of the vein and give you a good result. Okay, right. Okay, right. So all of you know how to make this foam. You take the sclerosant and air in 1:4 ratio. 1 milliliter of sclerosant, 4 milliliters of air, and mixed it. Okay, and inject to a vein via a butterfly cannula. Okay, and you should apply compression after that, so that it will spread through all the veins, and veins will be compressed and it will become fibrosed. Right. So as I told you, foam sclerotherapy has a high potency. And have you all seen patients coming with reticular and spider veins? So these are not necessarily varicose veins, but unsightly veins in the skin. Okay, it's kind of a early stages of chronic venous disease, but when you do a scan, the underlying veins may be normal. So for those reticular and spider veins, you can use sclerotherapy in a very diluted concentration. Okay, I'll come back to that. So when there is a truncal reflux present, like a SF incompetence or SP incompetence, so it's advised to use either thermal procedure or open surgery to deal with it. And for the residual varicose veins in the leg, you can use sclerotherapy. Okay, and also when there is varicose veins in elderly patients, frail patients, you can use sclerotherapy, which is a low risk procedure. Okay, it has good results in short term, but the recurrence rates are high compared to other treatment options. It's done under local anesthesia, low cost, and very less expertise needed. You just should be able to put a needle into a vein. That's it. Okay, but the recurrence rates are high, especially if you don't treat the truncal reflux before giving sclerotherapy. Okay, so adverse effects which are reported are cutaneous necrosis, hyperpigmentation, not common, allergies to the sclerosant, DVT. If you give the large amount of sclerosant, it will obviously go to the deep vein and can cause DVT, thrombophlebitis of the superficial veins, and if there is a connection between the venous and the arterial circulation, just like a foramen ovale, it can go through to the arterial circulation and cause problems like CVA, but those are reported but not common. Okay, so if the patient has allergy to sclerosants, you should not give sclerotherapy. Right. Should we give ST foam for every patient? Not really. So what are the indications to give ST form, right? So otherwise, sometimes when we see a varicose veins, we feel like giving foam injection to all the varicose veins, and we think that it might help us, but not really. Okay. So if the patient is frail, if the patient is very elderly, if the life expectancy is not more than 2 years, and if the patient is sort of troubled by the varicose veins, yes, you can use ST form. Okay, whatever the anatomical problem is. Okay, so recurrence is an acceptable thing there. Okay, if the patient doesn't want to get surgery, doesn't want to have laser, then yes, you have to explain that, okay, we treat you with foam, but you can have it. Again, recurrence risk is high. If patient accepts it, yes. Then ST form can be used for reticular veins. You can see in this picture, these are not varicose veins as such, but reticular veins which are unsightly, cosmetically sort of disfiguring. Same here. Okay, so you can use sclerotherapy. For spider veins which are less than 1 millimeter in diameter like this, you give the diluted sclerosin, 0.5% STD. Usually the sclerosins come in 3% concentration. You have to dilute it with distilled water to make it 0.5 and give directly. Okay. If the vein is more than 1 millimeter, you can give foam with the diluted sclerosin, make a foam with air and give. Okay, right? So those are the indication to give ST form, right? So therefore, I advise you to get a duplex scan done and identify what is the underlying problem before going and inject, because otherwise patient will come with your recurrence. Okay, right. Few words about thermal ablation, EVLT. I am not going to go into details. So where we use laser, okay, we put a small fiber through the vein and place the tip of the fiber close to the junction and give laser and constantly pull it back, giving laser, so that it will fibrose the venous wall and stop blood from flowing through that. Okay, so that's what we do in EVLT. So results of EVLT, healing rates are almost as same as the surgery. So therefore now we hardly do surgery for varicose veins, but surgery is still there, but most of the time we can get away with doing EVLT. Okay, right. This is us performing EVLT at NINDT, and RFA, again this procedure will be the same. Okay, but the physics of the procedure is different. If you are interested, you can read about it. Okay, so both these techniques we do under tumescent anesthesia. Tumescent means we use cold saline. We put lignocaine with adrenaline and sodium bicarbonate and inject it under ultrasound guidance around the vein. So that vein is going to be floating in a halo of anesthesia. So when you do laser, so these high temperatures which are being generated during the laser procedure will not be transmitted to the subcutaneous fat or the skin. Okay, and also it will give an anesthetic effect. Right. So it is obviously give you faster recovery, because we don't even admit the patients for laser nowadays. We get down the patient, do it and send the patient straight away home. So low morbidity, faster recovery, patients can get back to work quite soon. Okay. The rare complications would be thermal damage if you don't give the tumescent anesthesia properly, and also the pigmentation if you try to do the laser very close to the skin. Okay, and infections are of course very rare. So other endovenous techniques which are not being used in Sri Lanka but are used in other countries are steam therapy, cryoablation, mechanochemical endovascular ablations. Means we give a glue, we apply a glue into the vein and sort of close the vein with that. Okay, in most of these techniques you don't have to use tumescent. Okay, right. Long-term efficacy, of course these are new techniques, we don't know. Open surgery, few words about open surgery. I'm sure you must have seen most of you doctors must have seen open surgery being done. It was the treatment option for varicose veins in the past, but nowadays we do it only for selected population, patient population. What are those indications? One thing is if the vein is very large, let's say the diameter of the vein is about 2 centimeter. If it is more than 1.5, now normal diameter of the vein is 3 millimeter. If it is more than 3, it's varicose veins. But if it is more than 1.5, then the laser treatment would not work because it's too large for it to work. In that kind of a situation, you can go for open surgery. Okay. Otherwise, if the vein is tortuous, that means it's not straight and it's tortuous from the beginning to the end, then you can't negotiate the laser fiber through that. Then sometimes you will have to do open surgery. And if the vein is very close to the skin, sometimes usually these veins are situated in the subcutaneous compartment in the fat. But if it is subcutaneous just next to the skin, then it's not safe for us to do the laser because it will burn the skin. Okay, so those are the rough indications for us to go for open surgery. But obviously the popularity is declining now. It needs anesthesia, regional or general, and comparatively high rates of complications, more bleeding, wound infection, groin seromas, collections, infections, pain, more pain, increased hospital stay, more time for the patient to get back to work. Okay, right. So results, I said EVLT effectiveness is comparable to open surgery. Okay, so but if the patient's venous anatomy is suitable for both EVLT and surgery, you can go ahead with EVLT because it has more or less equal results with open surgery. Okay, and obviously less complications compared to open surgery. Right. This is other important part. How are I going to follow the patient up after any treatment of varicose veins? Because sometimes we treat these patients and they'll come back to you and ask, so when can I go back to my normal life? When can I start my job? Likewise, most of these procedures, once we do, we put compression for 1 or 2 weeks. For example, in laser, we put compression for about 2 weeks, but with the compression stockings on, patient can go back to normal life. They can go back to the job. They can start walking. We advise them not to do any vigorous walking or running for about 2 weeks, but they can obviously go back to normal life, job and walking after the treatment. Okay, recurrence risk. This is the most difficult question to answer. Sometimes patients expect a warranty from us. Once they get the treatment done, they need a warranty. How long will I be varicose veins free again? It's a difficult question to answer, but can roughly say the recurrence risk after getting EVLT is less than 10%. But that depends on patient's risk factors. If the patient is very obese guy, of course, they can have a recurrence sooner than that. Okay, if the patient develops DVT again, sometimes he can get a recurrence somewhere else. Okay, so recurrence risk is not predictable, but fortunately, it's less than 10% for most of the population. Place for lifelong compression. Patient might ask you, should I wear compression stocking lifelong after this thing? No, not for everyone, but if a patient has got a venous ulcer, treated and healed, and those category of patients will be benefited by using lifelong compression. It will reduce the ulcer recurrence rate. Okay, only that category of patients. Right. Okay, few messages for you to take home with. Right, reassurance is the most important medicine in the management of varicose veins. Always reassure. Okay, don't reassure and send them home, but before starting treatment, reassurance is important. Etiology of the most varicose veins, we don't know really, because there's a debate whether the venous wall become degenerated and dilated and then secondary valve incompetency comes, and sometimes some people say primarily valves become incompetent and then becomes dilated. You don't know what happens, but etiology of most VVS, varicose veins, unknown. Okay, so walking is encouraged after varicose vein treatment. Don't ever ask them to be in the bed. It increases the DVT risk. Okay, and use drugs for varicose veins like Daflon very carefully. I mean, you can give it, but don't expect them to do magics. Okay, so there are very narrow populations of patients will be benefited with the drugs, so use it carefully. Early interventions are needed for bleeding varicose veins. Be vigilant about long-standing venous ulcers. Don't ever miss a Marjolin's ulcer. Thank you very much, and thanks for listening. And I would like to answer any questions if they are there.
Thank you, Dr. Sachith, for that enriching lecture on varicose vein and its management in the primary healthcare setting. So there are a couple of questions. I think one you have already touched upon. The question was, are there any medical drug treatment in the world for varicose veins other than surgical options? I think Dr. Sachith already mentioned that. And the next question is, do we need to do duplex scan for the lower limb before the treatment of varicose veins?
Yes, in my advice is yes, due to several reasons. One thing is, unless there's life-threatening bleeding from the varicose veins, it's not an emergency as such. Okay, so therefore, I think planning of the treatment is very important before you starting it. Okay, so duplex is needed not for the confirmation of the clinical diagnosis, but to map the disease. You know, if you understand the anatomy of the superficial veins, so it consists of the greater saphenous vein, the small saphenous vein, and they go and join to the deep veins at the sapinopopliteal and the sapinofemoral junctions respectively. Most of the time, varicose vein happens because of a reflux or the incompetence at those junctions. But sometimes it can happen without a reflux in the those junctions, but there's a problem in the perforator veins. Okay, rarely you can have isolated varicose veins without any reflux in those veins. Okay, so you should know that fact. Other thing is, you should know the size of the greater saphenous vein. As I told you, if it is very large, the minimal invasive techniques like sclerotherapy or laser will not work. Okay, and you should know the cause, and most importantly, you should know how the deep veins are, whether there's a reflux in the deep veins and whether there's obstruction in the deep veins. Assume there's obstruction in the iliac veins somewhere, so treating varicose veins is not going to help the patient. Sometimes it can make the condition worse because the venous system is obstructed from that point upwards. So treating the superficial veins is not going to help you. So therefore, in my advice is always you have to get a duplex scan done. I mean, any doctor can do that. You don't need any sort of hi-fi radiology knowledge for that. Even vascular surgeons, we do it. We are not trained radiologists, but you just have to locate the vein and see whether there's a reflux, and you have to measure the size of the vein and just check the deep veins. Okay, so in my advice, yes, better to get the duplex scan done.
I think that cleared the doubt, and also I have another question for you since we have a little bit of time. So some of the professions that we are in, standing long hours, so for example the barbers and all those kind of professions, so I think that there is a risk in developing varicose veins for like you stand for a long time, and there may be other professions as well. So can you give us some advice on what kind of precautions that we can ask them to do, or what kind of advice we can tell them or give them to reduce the risk of developing varicose veins other than telling them to change their profession?
Right. So actually now, as humans, as a part of the development, so we have obtained a upright posture. So that puts a lot of pressure to our leg veins. Okay. So therefore, as human beings, all of us are at risk of getting varicose veins because of that. That's why it is very common condition. Sorry about that. So I think as a part of the development, we have obtained an upright posture, human beings. Okay, so that puts a lot of pressure on the veins in our legs. Okay, because most of the time we spend time on standing. So that itself puts all of us at risk of getting varicose veins. That's why the varicose veins are very common among human beings, and you hardly see varicose veins among animals. Okay, so this is the other question most of the time people will ask you. Okay, so people who are engaged in occupations which involves a lot of standing, like us surgeons, it's true that it sort of poses you at a higher risk than the others of getting varicose veins. But I mean, you can't do anything for that to prevent you from get varicose veins. You should not try and change the job. Why I'm saying it is, now we have studied this. This has been studied all over the world among occupations which involves long standing, surgeons. But when you get the prevalence or the frequency of varicose veins among those patients, it is not very high than the general population. I hope you understand what I'm saying. Now, if you study surgeons all over the world who spend time standing, and you assess the frequency of varicose veins, okay, and you compare it with the normal population. So for you to say that this occupation has put them at high risk, that number should be statistically higher, but it's not the case. Okay. Sometimes we get patients who are not involved in that kind of a job gets varicose veins. So therefore, you cannot sort of draw a line and say this occupation is at high risk, this occupation is at high risk, so we should need protective measures. Just like we say that patients who works in asbestos factories has a high risk of getting mesothelioma, the pleural cancers, but that is statistically proven. You need to use precautions, but not in this case. Okay, so therefore, I mean, there's nothing you can do about it. Okay, and the thing is, if you get varicose veins, it is not a very lethal condition. You can get it always treated. So therefore, you have to continue the job you are doing, and if you get varicose veins, get it treated.
Right, that's great. So I think there's one more question. I think they are asking about the drug and when to start the drug and the strength. I think you touched upon it during the lecture. If you just reiterate that.
I'll tell it again. The most commonly used drug is Daflon, which is a derivative of a herbal components. What it does is, it reduces the tone of veins. Okay, it will not reverse the reflux of the veins, but it will reduces the tone. So this tone is the one which is causing the discomfort. So when they reduce the tone, sort of the pain will reduced. Okay, so what we give is the strength is 500 milligram twice a day with meals. Okay, so you can give it for about 2 to 3 months and see whether there is a response. If the patient does not get a response, if the patient does not get a symptomatic relief, there is no benefit of continuing it. Okay, what you should do is, you have to select the patients carefully. The varicose veins in their early stages. Okay, that means varicose veins which are causing minor pain, discomfort to the patient. Okay, and if the patient say he or she doesn't like to get interventions, does. So those category of patients, you can start this drug and say, now this drug has proven some benefit in reducing the pain, but it will not cure your varicose veins. Let's try. So give it for a few days and say whether the patient tolerates the drug. If he or she tolerates the drug, you can continue it for about 3 months and see whether there is a response. If there is no response, then there is no benefit in continuing that drug. You have to stop the drug. Okay, and don't give this drug for complicated varicose veins, not for patients with varicose ulcer, bleeding varicose veins. This is not going to help. And patients with varicose ulcers, venous ulcers, then you have to treat the veins and put compression. This drug is not going to help. Okay, so therefore always educate the patient and keep realistic targets or the expectations before starting it. Okay.
Right. Thank you, Dr. Sachith. I think our learned audience got a very good perspective of the treatment of varicose veins in the primary healthcare setting. So all parts were covered and all questions were answered. So I would like to thank on behalf of the GMO Academic Subcommittee for coming here and delivering us a lecture to Dr. Sachith Abeywickrama as well. And would like to thank the audience as well. Thank you very much for joining in, and we hope to meet all of you all in a fortnight's time with another interesting lecture. And this is Dr. Rajiv signing off on behalf of the Academic Subcommittee of the GMO. Thank you.